Thank you, Hugo. We've seen a good overview. I think most of the points that I wrote actually have been now covered. There's just a couple of points which I'll start sharing with me and my co-chairs. One of the points, maybe if I can start off, is 100% repairability, and the whole spectrum is not just necessarily posterior, it includes anterior as well. And I presume most of the techniques can be adapted to either anterior or posterior. But the one question which I would like an opinion from the faculty is there any role of adding additional neochordae to what seems like a non-prolapsed on echo, but may contribute to future prolapse or failure or recurrence, and adding some neochordae to the anterior leaflet to increase your coaptation margin? And the second point is, how important do we feel that functionally we ought to still maintain a bi-leaflet orifice, because most of the things we are trying to turn into seem to be adopting the philosophy of making a unicuspid or maintaining a anterior leaflet motion with a rigid posterior leaflet. There is a mic there, and maybe I can ask, okay, David to start, please. Thank you.
Well, I guess the second point was about the posterior leaflet. I mean, I think our goal is not to make a unicusp valve anymore. I think our goal is to try and have some preservation of, it has to be posterior, and I just want to emphasize what Frank said about closing clefts all the way. These are very different cases, I think, when you have a large valve and a large orifice and a small valve and a small orifice. So small valve, small orifice, even if, like Hugo pointed out, you separate an indentation, we actually close them from the base up and keep doing saline tests. And as soon as we have confidence, then we stop. We try and preserve that little opening at the top just for that extra, sort of help opening and diastole. So I don't think we're trying to create unicusp valves. I think that was the old strategy, sort of the old Carpentier technique of just quadrangular resection created that sort of toilet seat effect, and you really did the shadow of the ring dropped out the posterior leaflet. We don't really see that anymore. Most of the echoes that we saw today from everyone showed a posterior coaptation surface that I think is very different now. And of course, nature almost does. I have a normal MRI, I show almost every patient just to show them how the valve works. In fact, it looks like a unicusp valve. The real nature really is an anterior leaflet swinging back and forth against a fairly immobile posterior leaflet. Do you agree, Frank? I do. I'll let you comment.
Yeah, just to pick up that last point, we looked at 100 so-called normal valves for fun in patients with aortic valve disease or coronary disease. And the first thing that we noticed was that papillary muscles are pretty regular horseshoe in the normal valve, and they're broken up in the disease valve, particularly the inframedial papillary muscle. But I'll just throw that in as a side. But when we looked at posterior leaflet motion, exactly as David said, there's huge variability in terms of how much there is. I think the mobile mural leaflet, however, if you can render the valve fully competent and keep much of that, that's desirable. I think just to abandon that and go for a monocuspid valve, it probably doesn't matter in the 78-year-olds so much, but I think in the younger ones it might, because orifice area is important. And there are some papers out there of mitral stenosis after mitral valve repair, so you have to watch that. Going back to your first point was the anterior leaflet and coaptation height. If you've got a good coaptation height, I don't think you need to worry about it. I don't know what David feels, but I don't like to artificially change anterior.
Yeah, I'll pass the mic behind me, but I think you're onto a very important point, and that is following up on what Frank talked about, doing a complete assessment of the valve. So fibroelastic deficiency, the classic disease, has very thin chordae. And so the one time we add secondary chord, we add a prophylactic neochord is when we see a tendency to prolapse and a very thin chord. So we see that even though the valve is not, that segment's not prolapsing, we have in fact started to add chords there in terms of the logic of very long-term durability. We don't just sort of necessarily say, oh, every A2 should have a chord. That I think would be too extreme. On the other hand, if we do a little triangular resection of P2 for FED and we look at P3 and there's just a little override and you look at the cord, it's very thin and elongated, we add cords there despite the fact there's no evidence of prolapse that day. Let me pass the microphone behind me and see what the comments are.
I agree with David. I think what you're introducing is the philosophy of the repair. The concept is not just to have the valve looking okay when you leave the OR. It's you're trying to repair the valve to give you long-term durability. And I think the thing that David just alluded to, and I think Frank, you alluded to in the echo, that if your echo people are anything like ours, they'll spend 20 minutes focusing on the P2 prolapse. And I think I've got no interest in the P2 prolapse. What we're interested in is the other parts of the valve. Are there secondary lesions? The prolapse of P3 that, if you leave alone, may produce recurrent MR in a year or two. So I don't think we have any evidence for the prophylactic replacement of Cordy, but I think we do need to spend a lot more time looking for and treating secondary lesions that may give you late recurrent regurg.
Let's hear from Hugo.
Well, there's two aspects here. First of all, the aspect of we aim for normal physiology, normal functioning at the end of the procedure. If you look at the normal mitral valve, your valves have a coaptation surface of 1 to 2 millimeters. So if we want to end up with 7, 8 millimeters, it's because we want durability and longevity, but there's nothing normal about that. So a monocusp valve is not normal either, but it is not a coincidence that none of us talked about an Alfieri stitch because we do not think it is a good normal physiology. That's the first thing I want to come to. Second, you brought up a very important point, I think. These small, friable, thin cords at the level of A2 that we sometimes see. We have to keep in mind that, first of all, by reshaping the annulus, and establishing good coaptation, there's going to be much less stress to these tiny cords. That's one thing. But the second thing is, if you look at Gaudi's cathedral from the inside, every tiny little support is important. Take away one and it can become brittle all over the place. So I think these tiny cords are important, but in my mind, if you replace them, you always have to replace them symmetrically. It is wrong, I think, to trust the cords that are at the level of A1 and the left-hand side of A2, and when they're brittle and friable at the right-hand side, you just replace these. No, you always have to come from both anterior heads of both pillars to both sides of A2, and always with cords where the repartition of strength on both ends is completely similar. Otherwise, you're going to change the function completely, and you may induce even more stress on the fragile cord that is sitting next to a vortex. You never know. And that would be wrong, I think.
Yeah, I think that's a very, very important point. And there is some papers now looking at 40, 50, how many sutures, how many pairs, blah, blah, blah. Sorry, Frank, you had to make a point?
So I agree with all my speakers. I just wanted to add a point. Particularly in the elderly population, you often find a valve where the prolapse is quite minimal. And you often find their cords are quite fragile. Be very careful if you start adjusting the anterior leaflet. You've got to be absolutely precise because you'll induce new MR if you're not careful. So it's very precise surgery.
Yep. Okay. Yes.
I just want to ask about annular calcification. You touched on it, and I think this makes a mitral valve, in degenerative mitral valve, a much more complex procedure. I think, Frank, you alluded today that you correct that by putting a pericardial patch. Is that always the case, or do you do an atrial slide plasty sometimes?
Well, it depends on the calcifications I know you know and the extent, but you do get these, particularly in the Barlows, I think because of a long period of excessive leaflet motion, this calcification all the way around the back. These leaflets are often very tall as well, and you've got leeway there. Cut off the leaflet on the calcium, so you keep all the leaflet tissue you can. Decalcify, and you cut it out very precisely. I patch to protect the posterior wall more than anything, but you can do an ordinary stitch down in the ventricle, always carry the patch further than you think, always make your stitches deep. And then you can do a horizontal mattress and leave some leaflet, which you can then fold forward and attach to your leaflet if it's short. If it's not, you can reattach the leaflet to the annulus. That's very different from some of the ones we showed of isolated calcification related to pulmonary muscle heads or particular parts of the valve. So you have to address what you see, but you can get these back together in most times, I think.
I think the resect and respect philosophies, and I'll show that on tomorrow afternoon, around calcification. I think these are both quite valid. Oftentimes you want to work around the calcium, and sometimes you're forced to resect it. So you should be very clever about that and not have one uniform way to take care of it.
Neil.
Maybe I could, as a comment, really a question for my colleagues. Do you think all calcification is the same? My feeling is it's quite common in the Barlow type valve, and I think it's actually much easier to remove in that setting. I think when you get the very elderly patient with fibroelastic deficiency and caudal rupture, you tend to have a different type of calcification that often creeps down the posterior wall of the ventricle, which in my mind is a much more dangerous thing, and I tend to leave that alone, whereas I tend to resect the calcification in the Barlow. And is that what everybody feels?
Quick.
I fully agree, Neil. In a Barlow, what we often see is the outward move, the posterior, of the base of the posterior wall, which causes the posterior ring to open up. And that is a stress area where these patients will actually download calcium. And it's easier to take that sort of calcium away than the 85-year-old lady with calcium goes into the ventricle. Be very, very careful. It's completely different.
David, you want to make a quick comment?
I just was going to say, I think that what something Neil hit on was important. Remember, a lot of the calcification you see in Barlow's is actually, it doesn't extend posteriorly, it actually heads toward the papillary head, just like the scarring you showed. It's just a more advanced case of that scarring that you showed, of this case between P1 and P2. That's straightforward to deal with. Your resection plane is away from the atrioventricular groove. The type that Neil's talking about in elderly people with prolapse or restricted commissure, this is a very treacherous case for decalcification, and it's challenging for replacement. That's why we've been working on some different hybrid approaches, which I'll show you tomorrow.
Yeah, it's a challenge for replacement as well.
A bit more there too. Cardiac CT in these cases is often quite useful, because the extent of the calcification into the free wall, the ventricle, and also its thickness. Sometimes it's full thickness. You've got to be very, very careful there. But you get so many varieties. You get these projecting spurs out into the prolapsing leaflets as well.
Yeah.
These are easy to resect.
Yeah.
I have two quick questions. Firstly, do you ever resect any anterior leaflet tissue in degenerative disease? And the second is a practical question. If you do need to reconstruct the leaflet tissue, what type of material are you now using for patches?
Frank?
Very rarely. And anti-leaflet endocarditis I resect, yes. But other than that, I try and keep it all. And I've switched to using core matrix. Whether I'm right or not, I don't know, but the pericardial options in many reports seems to stiffen up, although in one or two, I'm not sure that's always true. I've looked at echoes and so forth later on. But core matrix gives you a nice flexible platform, and if it really does repopulate with the patient's own cells, it could be very useful. But
David?
Yeah, we use autologous pericardium fixed in glutaraldehyde. Again, I don't have any experience with the core matrix. I hear mixed reviews from colleagues, so I think it's still a work in progress.
Do you treat it with aldehyde?
We do.
Yep.
And we in terms of resection of the anterior leaf, it's actually quite uncommon. We used to do it frequently because a lot of patients had, in fact, I was looking at our series last night when I looked at that technique slide. I hadn't looked at it in a while. And we did a lot of anterior leaflet resection historically, but with these, sort of the combination of, I think, of the Physio 2 sort of changing the shape of rigid rings and also employing bands sometimes in there that you oversize. I've always historically worried about that inconsistency between intercommissural height and septolateral height in Barlow valves. So that's why if you had a prolapse, I would take advantage of that and shorten the height as well of A2, whereas now with these newer rings and with, I guess, more comfort with chordoplasty, we rarely do resection except for endocarditis and occasionally for calcification.
Neil, Hugo?
Endocarditis is a different ballgame. Of course, you have to resect everything that is sick. But there are occasions, well, basically, you try to avoid resection of the anterior leaflet, but sometimes in combination with posterior medial prolapse, you can see some development of a huge balloon on A3 that, and then I usually do not resect. I just make an incision from the free edge all the way to the base and suture again, and you bury all the excessive tissue. It's probably better because you can loosen up that and start all over again if it doesn't look like nice afterwards.
Thank you. I guess it's just going to be impossible to cover all the topics, but I have two. Yes, yeah. Sorry, David.
I'll let you finish. So just before we stop, I want to ask these guys one quick question.
Sure. I would like to ask if there's anybody else in the audience who would like to ask a point, but then otherwise I'll invite Jean-François, who's also sitting here as an expert faculty, to tell us. He does the minimal invasive, slightly different to what Hugo does, and about 100% repairability.
And maybe I'll ask you a question first then, and we'll have everyone else respond. That's about Frank's point about these stress points around commissures. And we know that bileaflet prolapse and Barlow's are the most common valve, and anterior leaflet, but particularly bileaflet and excess tissue are the most common ones to recur from progression of disease. And you don't have to worry so much about stenosis if you just have a size 40 or 38 annulus. And so Frank, and maybe you could comment as well about how do you handle the commissures? Should we be closing more of them? Should we be trying to eliminate A1 and A3? Say the valve's a size 40 and you're operating on a 60-year-old. Should we try and eliminate these areas more? I don't know. I keep thinking about whether we're aggressive enough at the commissural level in terms of progression of disease. Should we convert size 40 Barlow's to size 32 or 34? You're not going to get stenosis in that patient, and would that minimize the risk of recurrence, which is still a problem? What do you think?
Well, you have given the answer, since very often when we have bileaflet prolapse, we have very large annulus. So the risk to have a stenosis is very few. So usually it's easier to fix the commissure and to have a suture on the commissure, and you can deal with the vast majority of the bileaflet commissure prolapse. I think so. I never use Gore-Tex on the commissure, almost never.
It's a very important point. Whether it's right or wrong, I don't know. But what I do is I look very carefully at captation height of both parts of the valve at the commissure. And you often find it migrates. The line of captation migrates as you look along. And if it's shallower, then I certainly do something about it prophylactically. That might be to close it off in a big one because you've got so much space. I have put cords in there occasionally. And occasionally I've done an actual commissuroplasty and just close it off with it. But I think if you've got good captation height and you've got a totally competent valve, perhaps I'm wrong, but I worry about it less.
The anterolateral commissure is almost never a problem. Posterior medial commissure is very often a problem.
Sure.
And I don't use Gore-Tex, I don't use commissuroplastic stitches. I usually do a papillary muscle repositioning of the intermediate head of the posterior medial papillary muscle. If you bring that down all the way to the basis of the posterior head, you bring it down 7-8 millimeters with one stitch.
Yes.
And at the same time, you bring down 6, 7, 8, 9 fan cords. So that is a very simple fix. And at the same time, you already cure part of A3 and P3 by bringing everything down.
Maybe I'm doing the wrong thing listening to my colleagues, but I agree about the posterior commissure, and I've been tending to put a lot of Gore-Tex cords to the posterior commissure in these valves, and making those cords a little bit shorter than the other cords, so you're almost kind of tucking that commissure in and making the smile. It tends to, so rather than closing it directly, you're increasing the surface of captation. I don't know whether you think that's the wrong thing to do, David.
I don't. It can be done. It's more complex than just advancing the commissure if the valve is large. Now, if you have a size 28 or 30 or 32 ring, I don't think you want to start closing, a quarter of the valve. But for these really large valves, I tend to do 1 or 2 magic sutures, and I really consider that sort of a commissural advancement, just narrowing the orifice a little bit. For the small valve, we would do what you would do, which is to add new support. I do think the fantastic thing, though, if you look at the sort of discussion this morning versus 3 or 4 years ago, is that clearly the repairability of valves is becoming much less of a sort of a interest than it was 4 or 5 years ago. I mean, repair rates seem to be, at least in sort of expert centers, really getting into this really extraordinarily high category, don't you think? And I think also our understanding of how to create really durable valve repair is increasing exponentially over the last 6 or 8 years. Oh, it's all exciting.
Thank you. It's a very, very interesting morning, and I, on behalf of my co-chairs and the society, would like to thank the expert faculty to give us a very good insight. May I now, thank you, may I now extend into the next session, because we started late in the morning because we were waiting for everybody to come through registration. So I'm going to invite the chairs for the next session to just quickly carry on, and I hope you can bear that and continue sitting. Thank you.